Hi, my name's Dr. Greg Pearson. I'm an adult general psychiatrist in private practice.
Hello, I'm Dr. Matt McDornan. I'm also an adult psychiatrist in private practice.
What Matt and I thought we'd do today is talk about anxiety. It's a very broad topic. Perhaps one of the most intriguing and ever-present aspects of psychological distress, Matt. And also perhaps one of the most responsive symptoms to treatment, the anxiety disorders responding traditionally very well to intervention. But I guess the starting point is, what is anxiety?
Yeah, I think that we've got to be a bit careful because we're talking about something that is a normal human response to stress, but also a syndrome in psychiatry, and something that we're all experiencing possibly every week or so. And you know, if my son didn't get off the bus and I wondered where he was, I would be anxious.
Well, exactly, Matt, and you know, that talks to what a fundamentally vital role anxiety plays in our life.
Yes.
If it wasn't for anxiety, we would not survive.
Yes.
We'd have no fear. We would engage in risky behaviour. You would walk in front of traffic, or we'd walk off cliffs, or we would die. So, you know, at one very fundamental level, anxiety is a survival instinct.
Yes, it's about the perception and anticipation of danger in the environment, really. And you can see the evolutionary advantages to having that system.
Yeah, absolutely. Yes, without it we wouldn't have survived as a species.
Yeah.
And so it's absolutely essential. And because of that, and I think this is what's really difficult to understand once anxiety becomes problematic, because of that, it's an incredibly safe experience. It's a life-preserving experience. But it is so perfectly designed to be intolerable. There are very few feelings in the world worse than anxiety.
Yeah. And I think that we're talking about a disorder when these experiences, which we'll flesh out in a minute, become ingrained and common and outside of you know, what's normal, for a better word. So if, for example, if I had an anxiety disorder, a generalised anxiety disorder, and I was fearful of a catastrophic bus crash and my son was never allowed to go on the bus, that's more what we're talking about, isn't it?
That's right, yeah. So where anxiety becomes a disorder, where it impacts negatively on someone's experience of themselves or on their functionality of life.
Yeah.
And it's very difficult to talk about anxiety with not talking about avoidance behaviour, because anxiety promotes avoidance. That's the natural and normal response to feeling anxious. And so it carries with it an incredibly powerful set of behaviours that serve to try and neutralise it.
I think, to me, Greg, you know, if we talk about anxiety, I've always explained it to patients by having three dimensions and then this halo of avoidance behaviour around that. So,
well, go on.
So the three things that we can possibly pull apart is that there's a physical component here. So there's all of the autonomic and endocrine-like responses to stress, which are hardwired into all of us. And
so these are the basic physiological mechanisms that exist in the body that get activated in a situation of perceived or real danger or threat.
Right, so there's a physical component, we can come back to that.
Yep.
There's a mood component. So in anxiety, it tends to be a sense of apprehension. It's like something's about to crystallise and some dread, something awful's about to occur. And then the third thing is the thinking patterns that are generated from this. So that's really where psychiatric diagnoses differ, and they try and categorise the forms of thinking that occur in anxiety disorders to separate them out.
Well, perhaps before we get onto the disorders, let's talk a little bit more about
The physical.
the nature of anxiety as being adaptive and helpful, because it's not just about life preservation, it's not just about threat, is it? It's about the enhancement of performance, that a small amount of anxiety can be really helpful,
Yes, it can.
that we can do better under pressure.
That's right. And so that relationship is famous in psychology, the Yerkes-Dodson curve. It's the idea that if you take a well-trained, intelligent person and apply stress to them, they'll respond.
Mm-hmm.
So that's what a sports coach is doing,
Mm-hmm.
or a captain in the army, or a good manager, or a motivational speaker. They're making sure that your abilities match the stress that's there, and then they'll get more performance. But there's a proviso. If you apply too much stress, then your performance drops off.
And it drops off very quickly.
Yes.
So in that state of overwhelm, our capacity to function becomes impaired
Yes.
dramatically.
Yes. And it's not the kind of place you want to stay. And people who can't get out of that are, some of the patients that we see, aren't they?
Yeah, absolutely. And perhaps we could also talk about the panic reflex, because that's also a sort of cornerstone element of the anxious experience. And this is a reflex that fires off extremely quickly under extreme threat, I guess I'd say. So the analogy I'll often give patients is if they were leaving my rooms that day and they were to walk across the road and a car came hurtling down the road towards the pedestrian crossing, hadn't seen them, they thought they were going to be hit by the car, they jumped out of the way, narrowly missed being hit, they would have a panic attack. There would be this incredible surge of adrenaline.
Threat response.
Absolutely. Instantaneous threat response.
Yeah.
And this relates to, as you were saying, the nervous system firing off and all sorts of hormonal contributions to that. But the experience would be one of incredible fear and numerous physiological accompaniments to that. So heart would be pounding, mouth would be dry, hands would be shaking, legs would be like jelly, breathing up, a state of absolute overwhelm. But in time that would settle because the threat was removed, and afterwards the person would feel exhausted,
Yeah.
but would be safe.
Yeah. So an entirely normal response, really,
Yeah.
to
yeah.
a threatening situation. So that's your nervous system anticipating danger and risk and responding as it should.
That's right. And perhaps another illustration is the night before a big exam. That sense of apprehension and worry, feeling sort of tense and keyed up, too activated to sleep. And that being something that would be almost universal
Yes.
under those
And
circumstances.
That's right. It can, that level of anxiety, leading into the exam might have been highly motivating. I mean, it can allow for preparation and mental rehearsal and activity. You can draw down on that if you're in a place of some poise to motivate you. And I think that they're understandable reactions, aren't they?
Yeah, exactly.
But I mean, this is one thing I hear from people a little bit is it's just anxiety. Imagine if we, applied that kind of notion to, say, autoimmune diseases. So, your immune system is really deciphering what is you and what is the external environment. It's a somatic form of memory. If it gets it wrong and your body attacks itself, you're in a lot of trouble medically. What if this threat response that, you know, allows you to prepare for exams or jump out of the way of a car, all of a sudden starts misfiring too frequently or in the wrong situation?
It's a really good analogy. It's like your body turning against itself. It's like an autoimmune illness.
Yeah, it's like an old part of your wiring, an evolutionary sense, which we share, by the way, with all the mammals, going off in the wrong setting too often. That is not a benign state, as anyone with an anxiety disorder knows.
No, and I think, Matt, you know, just speaking further to that, it's a common state. Anxiety disorders are common. It's also a very disabling state that it impacts substantially on people's capacity to function, but also it's a very treatable state.
Yes.
So let's go on and talk perhaps about the anxiety disorders, shall we?
Yes, so I think to point out that that physical autonomic response and also the feeling of dread is common to all of the anxiety disorders in greater or lesser amounts. It's the form of thinking that really separates out the different anxiety disorders. So, for example, generalised anxiety disorder is characterised by worry. So a ruminative, circular type of thinking, often future orientated and negative in its outcome, that comes up over and over again, and we might try on certain antidotes of reassuring yourself or distraction, only to find that it again reboots. The subject matter in that form of thinking can change from person to person. It can be their finances or family or health or so on. But it's really the form of thinking that is central to the diagnosis, isn't it?
Yeah, absolutely. And the fairly persistent experience of that as well.
Right, so there's that
in
over
the event,
time qualifier.
Yeah, in the event of a stressful event we will worry, but this is about worry that continues most of the time, most days, accompanying this sense of tension.
Yes.
And apprehension. And the worry, you're right, it can be, as you mentioned in an earlier video, it can be about something catastrophic. Okay, about a tragedy or a catastrophe that might befall you. But sometimes those worries are about extremely small things.
Yes.
What to wear, what to eat for dinner, what to buy at the shops. That everything becomes difficult, and indecision then becomes a big part of that.
Yes.
And understandably from that generates this sense of over-analysis, that there are multiple options, which one is correct, and that can be really paralysing. And yeah, that describes the state of generalised anxiety or a generalised anxiety disorder.
What about social anxiety, Greg?
Yeah, well, that's also a really common form of anxiety. And this is about anxiety related to the social experience or performance situations. So perhaps the characteristic, normal part of that social experience is when someone has to stand up in front of a group of people and deliver a presentation. So most people will feel a degree of anxiety or apprehension about that. Some people can do it without any concern whatsoever. And then at the other end of the spectrum, there are some people who find that absolutely agonising and abhorrent. And to stand up in front of a group of people, they find themselves extremely uncomfortable, tongue-tied, unable to think, dry in the mouth, quite panicky. And that experience becomes a really terrifying and horrible experience for them.
Yes. Yes, to me, social anxiety outside of the performance situation is, it's a disabling condition, given that we live in a social world. That people tell me that they're intensely tuned into the cues of others.
So we're talking now about engaging in social activity, normal everyday social activity.
Of course, yeah.
This can be a one-on-one conversation, often with someone they don't know particularly well, or a general conversation.
Yeah, and even if really the kind of common themes are people are very tuned into their own performance within that simple exchange. So, you know, if the other party raises their eyebrow or there's a tone in their voice, it will be concluded very quickly that the other person holds a negative view of them.
Mm-hmm. That's right.
And they often tend to replay conversations later on looking for errors they've made. There tends to be that sense of self-reference. You know, if they're in a public area, lining up in the bank or eating publicly, they'll feel like that they're making errors all the time, and they're disabled in that.
Yes, and somehow that these errors are illuminated and observable to
Yes.
people, and this incredible sense of self-consciousness
Yes.
that is completely overwhelming and unavoidable.
Yes.
Very self-referential in the
Yes.
way they think, and vigilant for scrutiny,
Yes.
and the fundamental fear being that they will do something wrong.
Yes.
They're going to make a fool of themselves or humiliate themselves in some way.
And it's common for people to label that as paranoid.
Yeah.
But really, it's nothing to do with paranoia, not psychotic-driven paranoia. It's that acute self-reference, isn't it?
Absolutely. And unfortunately, they become sensitized then to social situations. And apropos of that, they become avoidant of social activity and increasingly sensitized to those environments.
What about the curious entity of simple phobias?
Yes, and it's one we don't tend to see an awful lot of.
No.
But
Maybe our psychological colleagues do.
Yes, I'm sure they do see a lot more of that. So that would be something like a spider phobia, or a snake phobia, or a storm phobia, perhaps.
Yeah, it's an object that's otherwise probably benign, that an intense and irrational fear is organised around, isn't it?
Yeah, that's right.
They're not really explainable. People have tried to look into whether the subjects of phobias have any survival value. I mean, is it useful to be phobic of snakes and spiders? On first take, yeah, it probably is. But in the research, phobias are not always directed to survival-like points of threat. So it's hard to explain a phobia of I guess blood or what else?
Yeah, well, now that's a really interesting anxiety disorder, and not one we get to speak much about, the notion of blood injury phobia.
Yeah.
Because that ignites a different anxious response, and we rarely get to see this anxious response. And this is a response of autonomic activity that causes fainting and lowered blood pressure.
Yeah.
And occasionally you see that in panic disorder, but rarely where people actually faint.
I mean, people have tried to integrate these different dysfunctions in your autonomic system in this idea of polyvagal theory, haven't they?
Yes, that's right.
Yeah, different levels of autonomic dysfunction, innovating different parts of your neurology and so on. And there are different flavours to that, of course.
Yeah.
What about PTSD?
Yeah, well, Matt, it's an anxiety disorder we're seeing a lot more of these days. And I often like to conceptualise PTSD by relating it to grief. Because I think that's the natural model for PTSD. That this is an event that is overwhelming at some level, that it's almost impossible to engage with again in a way that's in any way positive because of the loss and sense of bereavement involved, but that it's re-experienced through dreams or otherwise, and that ultimately, and positive misidentification, and sometimes hallucinations, actually seeing the lost person. And I find that a helpful analogy sometimes for people suffering PTSD. So what we're referring to is an event where the sense of personal threat and overwhelm is profound. So that it really acts as a threat to the person's life or their integrity, and it overwhelms the brain's cognitive capacity to
There's a loss of control,
process,
isn't there?
loss of control, loss of power, and the threat of complete destruction or annihilation. And so most commonly we hear about this in war veterans, and in fact it really grew out of the Vietnam veterans returning from Vietnam to the United States of America. But obviously we've recognised it for a very long time in other forms. And in these days, I guess we see it in people commonly after motor vehicle accidents. We see it in first responders, police, AMBOs and fireys. It's a curious, corrosive presentation often, because frequently in that population it is about an accumulation of exposure to trauma, reaching a critical threshold at some stage.
Yeah, I think that's right. It's sort of artificial in part to talk about PTSD all in one group, isn't it? Because to have single event PTSD, like someone in a bank robbery or a sexual assault, and then there can be cumulative things, and the impact on a human is very different also in the stage of their life. For example, what happens with children and survivors of developmental traumas. To me, it's of course there's those physical experiences and there's the moods of anxiety. I suppose people with PTSD also complain of other mood states as well. They can be irritable and numbed. And I guess that one of the kind of key concepts in PTSD is it's an aberrant encoding of memory. So if most people regard their normal memory as narrative. So, I could say, when was the last time you went for a surf, Greg? And you can flick through, the kind of library in your mind and pull out a memory system and tell me in a story-like way, with sensory information and emotional information and so on, and it's at your own will.
Yep.
And you can put that back and move on. If you are rendered helpless and you're under threat, you don't encode memories necessarily in that narrative format, do you?
No, that's right.
So they tend to be fragments of sensory data, often with terror behind them. And I guess it's, for a better word, they're bytes of intense memory.
Yeah. And they're stored as a result of that in a very chaotic way.
They are, and they're not in a narrative, they're not in a story.
That's right.
And they don't tend to have as much of a time depth. So by that I mean, I could say, when was the last time you went for a surf? And you might think, it was about, 3 weeks ago. People don't talk like that with these kind of memories. The time depth isn't there. It's like it just happened or it's happening. And I think that forms the basis of that whole re-experiencing side of PTSD. It's not a memory system necessarily under volition, under control. It's intrusive and terrifying. And people have to protect themselves. In fact, people have to protect themselves from all of these experiences.
They do indeed.
And really that's what we're leading on to about this kind of halo of avoidance.
And so, yes, re-experiencing phenomena, flashbacks and nightmares. So flashbacks are an intrusive, involuntary experience, often very visual, but they can be in other sensory modalities as well. So some people get auditory flashbacks and will get somatic flashbacks or olfactory flashbacks. So feeling the pain, smelling the smells, seeing elements of this trauma that sometimes are very pictorial, almost like a video being played out. And they recoil from these experiences with a sense of abhorrence and overwhelm. And nightmares, obviously, nightmares are often very detailed and very representative of the trauma, but not necessarily accurately. No. It can be more metaphorical in
thematic.
a nightmare. And nightmares are they're really tough. I mean, people can recoil from a flashback and manage to avoid it somehow. Nightmares are an uncontrolled experience, and and people will get sort of re-traumatized at night as a result of that.
That's right. I mean, if you can't, it's a basic human requirement, isn't it, to be safe in your sleep?
Yeah.
Imagine not being safe in your sleep.
Mm.
And someone's partner is the best person to ask about this, because they'll invariably say they grind their teeth, they talk out, they thrash around, and I end up on the couch. And the normal kind of relative muscle paralysis that we enjoy in REM sleep is off.
That's right. So normally when we're dreaming, we're paralysed.
Partly, yes. Some functions can intervene, like our breathing and so on, but
Yeah.
we are, relaxed. Those sort of patterns in your neurology don't align if you've had a trauma, do they?
No, that's right. They get very jumbled and distorted.
Yeah.
And then again with PTSD, this whole raft of avoidance behaviours, cognitive avoidance of
Yeah.
Reliving the trauma experience, and all sorts of behavioural avoidance. And the analogy I like of PTSD is the linen cupboard analogy. Are you familiar with that one?
Tell us, Greg.
That is that most people's linen cupboards are pretty messy. It's rare that you go to a linen cupboard where the fitted sheets are beautifully folded and the single sheets are there, the pillowcases, the doubles, the queens and so forth. It's usually a jumbled mess, and that's the jumbled mess of PTSD, that in an effort to retrieve the memories and work with the traumatic experience, it's like opening the cupboard doors and not knowing where to go to retrieve the piece of linen that you want. And ideally, the treatment then becomes taking out the linen, refolding it, reordering it, and putting it back in context. And I think it's a lovely metaphor for PTSD.
There's lots of hard work in that.
It's not very pleasant. And man, what about OCD? That's a really obsessive compulsive disorder is a curious illness, isn't it?
It's always been debated as to whether to include it in the anxiety disorders. It seems to have its own kind of dimensions. I think, OCD, obsessive compulsive disorder. Again, the starting point is to look at what an obsession is. So it's a thought that's intrusive, that you find uncomfortable, that you recognise is from your own mind, generated from you, that's recurrent, and if you try and suppress it, there's a sense of tension that builds.
And we all get them.
We do, but imagine getting them a lot.
Which is the other crucial element. It's not, we can all get sudden crazy ideas. Where did that come from? A very odd thought can be aggressive or sexual or repulsive in some way, distressing in some way, but we can dismiss them very, very quickly.
Yes.
But the person with OCD cannot. It becomes this circular, sticky process where the thought continues and continues and the distress increases.
That's right. And we used to try and look at the different kinds of OCD on the content. So whether it was, sort of fears of germs or doubts about security, like if I turned the oven off or locked the doors, or commissioning a terrible act of killing someone. And really now a lot of people talk in terms of the intensity of this. So how much reality testing is there? How can you go, that's not true, I'm not going to do that? And the compulsion side is really a self-generated antidote, isn't it?
Yeah, that's right. It's an avoidance behaviour.
Yeah, you could see it that way.
It's a behaviour that neutralises the anxiety, allows the person to disconnect from the frightening thought.
Yeah.
And it's often a repetitive behaviour. So for the hand washer, for the person who fears contamination and washes their hands, there will be some stage at which they will conclude that enough hand washing has taken place and they're okay. And
only for a brief time, though.
Only for a period of time, that's right.
And then the pattern recurs.
Yeah.
Out of all of the anxiety disorders, it was one of the first ones to really be seen as a neurological event, wasn't it? So
well, that's right. We were, with imaging studies, able to demonstrate abnormal activity in the anterior cingulate, and that was very early on that we could.
And Panic, Greg. We've talked about what happens when you panic, but there is a panic disorder.
Yeah, that's right. So that panic reflex that I mentioned that could fire off in the setting of threat can occur spontaneously. And it tends to do that in circumstances where there is a natural elevation of anxiety. So the classic one is in a shopping centre, an area that is noisy and bright and confined. And out of the blue, someone begins to feel that panic reflex beginning. But they don't say to themselves, gee, there's a car coming down the road, I'll jump out of the way, that was close, nearly got killed, I'm okay. They say to themselves, what is going on? I feel really strange. Maybe something's wrong with me.
Yes.
I can't breathe. Maybe I'm having a heart attack, or maybe I'm having a stroke, and this anxiety spirals out of control quickly and dramatically.
That's right. It's that part of us all that needs a logical resolve that takes it to another place, isn't it? So the attribution of the experience.
Yeah. So often the patient the person will remove themselves from that circumstance. So if it's in a shopping centre, they will flee to the outside, and gradually their anxiety will diminish, a little bit like after the car has passed, reassuring oneself that it's okay. What then becomes difficult is the next time the person has to go to the shopping centre, because they will anticipate exactly the same experience. It's been a traumatising experience. They're doing exactly what their brain is telling them to do. Don't go there, that's a dangerous place. And we begin to see the development of secondary phobic avoidance.
So let's talk about avoidance.
Where would you like to start?
Well, it's common to all of these disorders, isn't it?
Yeah, absolutely, absolutely. Anxiety is extremely unpleasant. At an instinctive level, we are programmed not to engage in activities that make us anxious, so we avoid those activities.
And thoughts.
And thoughts, yes, absolutely. And that is a very important part of this, is cognitive avoidance.
That's right. I mean, to me, it has a rational and an irrational part to it. So, the attribution rational part is what you think has caused the panic. So, if you think going to Woolworths has caused a panic, if you make that conclusion, then the next bit is partly logical, and that is that, well, I won't return to Woolworths because I have concluded that that's making me anxious. The problem is that this becomes overgeneralised and applied to lots of different scenarios, and in the end, in behavioural terms anyway, your world starts to shrink, doesn't it?
And ultimately someone could be housebound.
Yes.
I haven't seen someone with that level of what we call agoraphobia for a very long time.
Yeah, that's right. It's also one of the first things to talk about with someone with these kind of anxieties, because in their mind, the avoidance is their own self-developed treatment. And where they're saying, well, no, this is the place to start to get better. We want you to hand over that avoidance. And it's a difficult tension, because someone's come up with a whole array of behaviours that might briefly have worked, but they become ingrained, and we're asking them to forfeit what they think may have worked.
Exactly. And it's antithetical to their thinking.
Yes.
It is completely opposed to what their mind and their body are telling them to do.
That's right.
But avoidance behaviour is very reinforcing of anxiety, and the treatment then is a treatment based on exposure to the feared situation, coupled with anxiety management.
Yes, that's right. And we're going to go and talk about those two key areas of anxiety management in another session, aren't we?
We are.
Thank you very much for joining us today.
Thanks very much.